Have you ever wondered why pregnancy places such a massive demand on the cardiovascular system, and why many of the most dangerous complications in midwifery are actually cardiovascular problems in disguise? From early pregnancy to labor, delivery, and the postpartum period, a woman's heart and blood vessels are forced to adapt rapidly, dramatically, and continuously. If these adaptations go wrong, the consequences can be severe for both mother and baby. In this video, we are going to break down the entire cardiovascular basis of midwifery, step by step, from normal physiological changes in pregnancy to hypertension disorders, cardiac output changes, drug safety, and postpartum cardiovascular risks. By the end of this lesson, you will understand not just what happens, but why it happens, and how to think like a clinician in real midwifery practice. So stay with me till the end, because missing any part of this video can leave dangerous gaps in both exams and clinical decision-making.
Before we begin, I need you to pause for a moment and slow down. This isn't one of those videos filled with flashing visuals or constant movement on the screen. You won't see heavy animations and you won't see a lot of text. That choice is deliberate. Because the real value in this video is not in what you see, it's in what you hear. If you give me your full attention for the next few minutes, this explanation will unfold clearly in your mind, one step at a time. So ease your eyes, settle your thoughts, and allow the voice to lead you through it. If you listen closely, you'll understand far more than you expect.
Pregnancy is a state of profound cardiovascular adaptation. The moment conception occurs, the maternal body begins preparing to support a growing fetus, and the cardiovascular system is the first to respond. One of the earliest changes is a reduction in systemic vascular resistance. This happens because pregnancy hormones, especially progesterone and estrogen, cause widespread vasodilation. Blood vessels relax, peripheral resistance drops, and as a result, blood pressure may actually fall during the first and second trimesters. At the same time, blood volume begins to increase. Plasma volume expands by up to 50%, while red cell mass increases by a smaller amount. This creates what is called physiological anemia of pregnancy, not because red cells are lost, but because plasma increases more than red cells. The increased blood volume is essential for placental perfusion, fetal oxygen delivery, and protection against blood loss during delivery. Cardiac output also increases significantly during pregnancy. This increase is driven by both an increase in heart rate and an increase in stroke volume. By mid-pregnancy, cardiac output may rise by 30 to 50% above pre-pregnancy levels. This means the heart is working harder every single minute to meet maternal and fetal demands. Despite this increased workload, blood pressure often remains normal or slightly reduced in early pregnancy because systemic vascular resistance is low. However, as pregnancy progresses into the third trimester, vascular resistance may begin to rise again, and blood pressure can return to pre-pregnancy levels or increase. These normal physiological changes form the foundation for understanding hypertensive disorders of pregnancy. Hypertension in pregnancy is not a single disease. It is a spectrum of conditions with different mechanisms and risks. Gestational hypertension is defined as elevated blood pressure that develops after 20 weeks of pregnancy without proteinuria or end organ damage. It reflects abnormal vascular adaptation, but does not yet involve systemic endothelial injury. Preeclampsia, however, is a much more serious condition. It is a multi-system disorder characterized by hypertension, proteinuria, and organ dysfunction. At its core, preeclampsia is a disease of endothelial dysfunction. Abnormal placental implantation leads to reduced placental perfusion, which triggers the release of anti-angiogenic factors into maternal circulation. These factors damage maternal blood vessels, causing vasoconstriction, increased vascular permeability, and widespread organ injury. From a cardiovascular perspective, preeclampsia causes increased systemic vascular resistance, increased afterload, and reduced organ perfusion. This explains why patients may develop headaches, visual disturbances, kidney injury, liver dysfunction, and pulmonary edema. The heart is forced to pump against high resistance, increasing the risk of cardiac failure. Understanding cardiovascular physiology is also critical during labor. Labor is one of the most intense cardiovascular stress tests the human body can experience. With each uterine contraction, blood is autotransfused from the uterus back into maternal circulation. This causes a sudden increase in preload and cardiac output. Heart rate rises, blood pressure fluctuates, and myocardial oxygen demand increases. In women with underlying heart disease or poorly controlled hypertension, this sudden cardiovascular load can lead to decompensation. That is why labor management in high-risk pregnancies must always consider the cardiovascular status of the mother. Immediately after delivery, cardiovascular changes do not simply reverse. In fact, risk may increase. After placental delivery, there is a sudden shift of blood from the uteroplacental circulation back into systemic circulation. This further increases preload and cardiac output. At the same time, extracellular fluid shifts back into the intravascular space. These changes explain why pulmonary edema and heart failure can occur in the postpartum period, especially in women with preeclampsia or cardiac disease. Postpartum hypertension is another critical cardiovascular issue in midwifery. Blood pressure may rise or worsen after delivery, particularly within the first 48 hours. This is due to fluid mobilization, increased vascular tone, and persistent endothelial dysfunction. Importantly, eclampsia can still occur postpartum, even if blood pressure was controlled during pregnancy. Drug therapy in pregnancy must always be guided by cardiovascular safety for both mother and fetus. Many antihypertensive drugs commonly used outside pregnancy are contraindicated. ACE inhibitors and ARBs, for example, are strictly avoided. These drugs interfere with the fetal renin-angiotensin system, leading to reduced fetal renal perfusion, oligohydramnios, skull abnormalities, and even fetal death. From a cardiovascular perspective, blocking angiotensin II in the fetus prevents normal blood pressure regulation and kidney development. Safer antihypertensive options in pregnancy include methyldopa, labetalol, and certain calcium channel blockers like nifedipine. Methyldopa works centrally to reduce sympathetic outflow, lowering blood pressure without compromising uteroplacental blood flow. Labetalol provides both alpha and beta blockade, reducing vascular resistance while maintaining cardiac output. Calcium channel blockers reduce vascular smooth muscle contraction, lowering peripheral resistance effectively. Another important cardiovascular concept in midwifery is venous thromboembolism. Pregnancy is a hypercoagulable state. Increased clotting factors, reduced fibrinolysis, venous stasis from uterine compression, and endothelial injury during delivery all increase the risk of deep vein thrombosis and pulmonary embolism. Pulmonary embolism remains one of the leading causes of maternal mortality worldwide. Cardiovascular assessment in midwifery must therefore be continuous and proactive. Blood pressure trends, heart rate, signs of fluid overload, respiratory symptoms, and urine output must all be monitored closely. A sudden rise in blood pressure, shortness of breath, chest pain, or reduced urine output should never be ignored. In summary, pregnancy transforms the cardiovascular system. Blood volume increases, cardiac output rises, vascular resistance initially falls and later increases. When adaptation is normal, pregnancy progresses safely. When adaptation fails, cardiovascular complications such as preeclampsia, heart failure, pulmonary edema, and postpartum hypertension emerge. Understanding the cardiovascular basis of midwifery allows you to predict complications before they become emergencies. It allows you to choose safer drugs. It allows you to manage labor and postpartum care intelligently, and most importantly, it saves lives. If this lesson deepened your understanding of cardiovascular physiology and midwifery, like this video, share it with your colleagues, and subscribe to Elite Medic Nexus. Turn on the notification bell so you never miss